Hi guys, good evening. Right, can you all see me? Can you all hear me? All right. So last week when we spoke about the carcinoma stomach. In the carcinoma stomach, we spoke about how the patient is going to present to you, the risk factors, the clinical presentation, the atypical, that is extra GI manifestations that we have, right? Then we spoke about how do you investigate. We looked at the Lauren classification, morphological classification based upon the upper GI endoscopy. Then you have the lymph node stations, right? So today we're going to talk about the stage-wise management of gastric cancer. So I'm going to talk about the stage-wise management. We'll talk about the stage-wise management of gastric cancer. We're talking about the stage-wise management of the gastric carcinoma, right? When you look at the stage-wise management, we'll look at the TNM classification and then we'll move across from there. Hi guys, good evening, good evening, good evening. I hope everybody is able to see me. Audio video fine. Quick feedback. All right, so we'll be talking about the TNM classification. To understand the TNM classification, we'll be using the same component that you have, that is the layer wise. You have the mucosa that is present. Surrounding the mucosa, you have the submucosa. Then you have the inner circular muscles which are present here. This is the component of inner circular muscles. Surrounding the inner circular muscles, we have the outer longitudinal muscles. Outer longitudinal muscles. Surrounding the outer longitudinal muscles, have the, as we all know, the epithelial lining is going to be formed on the mucosal surface, mucosal epithelium that you're going to have. Malignancy will develop from this point. There is no point. This is the mucosal surface that you have. Then next going into the submucosa, the inner circular, the outer longitudinal muscles, and the right. Just for the sake of understanding, I'll just comprehend the same. Now, when we talk about the malignancies, let's talk about how does a tumor is going to be present all across. So when we say in the TNM classification, you have the TX. The TNM classification, we're talking about the T staging first. Now here it depends upon the depth of the invasion. The T staging of the gastric cancer depends upon the depth of the invasion, right? Depends upon the depth of the invasion. Have TX where a primary tumor cannot be assessed. Here a primary tumor cannot be, if a primary tumor cannot be assessed, it is called as, if it is cannot be assessed, if it cannot be assessed, this is what we call as a TX, right? Then you have T0. T0 is there is no evidence, there is no evidence of primary, there is no evidence of primary. Then you have TIS. TIS is carcinoma in situ. TIS is carcinoma in, right? Now, when I say carcinoma in situ, it is basically intraepithelial malignancy, right? So, if the malignancy is limited to the epithelium only, right? If it is limited to epithelium only, this is what we call it as TIS. TIS is intraepithelial malignancy. It is going to be intraepithelial. This is considered to be an intraepithelial tumor. Remember, you will not have the breach in the basement membrane. The basement membrane integrity will be maintained, or it can also be considered with high grade dysplasia. Presence of high grade dysplasia will be considered as TIS, right? Then comes the T1 tumor. So when I say T1 tumor, it is going to involve, there is involvement of lamina propria. There is involvement of lamina propria, muscularis mucosa, muscularis mucosa, or submucosa. Now, this is divided into two subvariants that you have, that is T1A and T1B. Now, what is a T1A? Where it is only involving the lamina propria, where it is involving lamina propria or the muscularis. It is the muscularis mucosa. T1B, on the other hand, if there is involvement of submucosa, if there is involvement of submucosa. So when you look at whole diagrammatic representation that we have, which you have created down for you, the in the epithelial surface or the mucosal surface, you have the epithelium first. Just below the epithelium, you have the lamina propria. So I can say this happens to be the lamina propria. Under the lamina propria, you have the muscularis mucosae, your muscularis mucosae, and under beneath this, you have your submucosa. Under beneath this, you have your submucosa. I have to just highlight what you're trying to tell you. This is the epithelial surface. Then you have the lamina propria. And the muscularis muscularis, right? Now here we are talking about if a tumor that is being formed, if a tumor that is being formed, if it goes all the way to this point, your one, this is what we call it as a T1A tumor. If this involves the submucosa, involving the submucosa, this is 1B. Involvement of only epithelium is in situ high grade dysplasia. If it is involving all the way to that of muscularis mucosa, it is going to be T1A. If it breaches and goes into submucosa, it will be called as T1B disorder. It will be called as the T1B disorder. Continuing on to the next component, then you have T2. T2 is tumor invading muscularis propria. Tumor invading muscularis propria. There is tumor invading muscularis propria. So you see, tumor that starts from here, it is now going all the way into muscle. It is invading the muscularis propria. Invasion into the muscularis propria will be your T. It will be your T2, right? Then you have T3 that involves serosa. Tumor involving – tumor involving serosa. Now, if you say from here, it goes all the way across here, involving, it is involving all the way to the serosa. This is your involving of the serosa is also is considered to be a T3 disease, right? T4, if tumor perforates serosa, tumor perforating, the tumor is perforating serosa, it is called as T4, which is subdivided into T4A and 4. Now, what is T4A? T4A is just if it perforates serosa. There is perforation of serosa, that is 4A. If there is involvement of adjacent structures, if there is involvement of adjacent structure, it will be called as T4B. Right? Now, if you have the same representation, if the tumor invades, if it is invading the serosa, your T4A. But if it invades and goes onto the surrounding organs, say if this is the tumor depicted, that this is how the tumor is invading. There is, it could be pancreas, could be there, it could be spleen. So if it is invading any organ, that organ could be pancreas, it could be spleen. If any local organ is being invaded, this, right? So rather than trying to remember it in an uh, font, I mean, I say like a the entire data. Just remember this particular diagram. Yeah. So TIS if it remains in situ, T1A if it is involving all the way to the muscularis mucosa, T1B involving submucosa, T2 going into muscles, T3 invading the serosa but not beyond serosa, T4 is beyond serosa, T4B is adjacent organ. T4B is your adjacent organs, right? If I have to just quickly write it down, you can say this is your T1A, your T1B, this is your T2, this happens to be a T3. This is more comprehensive if I write it on this side. So this is how you can see the tumors are going to progress. Clear? So this is how those who are not able to comprehend. Quick recap on that as well. This is what we call it as the submucosa. This is what we have the submucosa. This is your inner circular muscle. This happens to be your outer longitudinal muscle. This happens to be your, this happens to be your. So this is how the tumor is going to progress. Right? So far, so good. Here, this is your T staging of the gastric carcinoma. Okay. Same way, you have the lymphatic that is going to be N staging. We have already learned about the lymphatic drainage of the stomach and its orientation. Right? Now, NX, that is regional lymph nodes cannot be assessed. Regional lymph nodes cannot be, your regional lymph nodes cannot be assessed. N0, there is no regional lymph node metastasis. There is no regional lymph node metastasis. there is no regional lymph node metastasis. N1, if there are 1 to 2 regional lymph nodes are involved. If 1 to 2 regional lymph nodes are positive, it is N1 disease. N2 disease is going to be 3 to 6 regional lymph nodes are going to be present. N3 disease is can be divided into N3A and N3B. N3A is going to be 7 to 15 group of regional lymph nodes are positive, and this is going to be more than or equal to 16 lymph nodes. If they are found to be positive with tumor, it is N3. So regional lymph nodes are on the basis of these arrangements. NX regional lymph nodes cannot be assessed. N0 there is no evidence of any regional lymph nodes. Then you have N1 1 to 2 group of lymph nodes. N2 is 3 to 6 group of lymph nodes. N3A is going to be 7 to 15, and N3B is going to be more than or equal to 16 group of lymph nodes. Uh, Metastasis, I don't think it is uh, any change, or I can say anything which is going to be difficult here. So M staging that you give is M0. There is no evidence of distant metastasis. There is no evidence of distant metastasis. M1, there is evidence of, there is evidence of distant metastasis. Right. This is all in all with respect to your TNM classification. All in all, the TNM classification of your gastric. Right. Now, once you have the TNM classification, let's talk about staging of the gastric cancer. We'll talk about the staging of gastric carcinoma. We'll talk about the staging of the gastric. We'll talk about the staging of the gastric cancers. Now, in the staging of the gastric cancers, okay. Now we have the following components. That is a stage 1. For a stage 1A, it has to be T1 N0 M0. It could be T1 N1 M, right? If it is T1 N0 M0, T1 N1 M0, it is going to be stage 1A, right? This is going to be stage 1B. If it is going to be lymph node is going to be 1, it is stage 1A is T1 N0 M0, stage 1B is going to be the T1 N1 M0. Okay. Another thing that you can have in 1B is going to be T2 N0 M0. T2 0 M0, that is a stage 1A and 1B. Now when you have stage 2A, for stage 2A, you have T1 N2 M0, you have T2 N1 T2 N1 M0, or T3 N0, or T3 N0 M, right? That is your stage 2A. Then you have stage 2B. Now in stage 2B, you have T1 N3 M0, then you have T2 N2 M0, then you have T3 N1 M0, or T4A N0 M. It's an increasing trend that you can see. I'm not adding anything, it's just sequentially say T1 N0 M0, T1 N1 M0, T2 N0, T1 N2. Say T1 N1, here T2 N2, here T1 N2, here T1 N3. So it is just becoming like one component up. That is your stage 2A, 2B, right? Then you have stage 3A, that is going to be T2 N3 M0, T2 N3 M0, T3 N2 M0, T4A N1 M, T4A N1 M0, that is 3A. Stage 3B that you have is T3 N3 M0, T4A N2 M0, T4B N0 M0, 4B N1, that is your stage 3C. Stage 3C is T4A N3 M0, T4B N2 M0, T4B N3 M, right? The last one is going to be stage 4. Now, stage 4 is the easiest to remember. It is NET, NEN, if M is going, if M is going to. Now, there's nothing spectacular about it. It is like one step ahead that you're going to keep on managing it. Now, there are different ways that you can actually remember it. If you have to comprehend it, this is the best way to go, that you slot them up. That is T1, that is 1A, 1B, 2A, 2B, 3A, 3B, 3C, stage 4. Okay? So this is how your gastric cancer is going to basically look across here. It's like a step ladder pattern. You have T1 N0 M0, then the next one is T1 N1, then you have T2 N0, then you have T1 N2, N1 का N2 हो गया, T2 N0 का N1 हो गया, then you have the next one, that is T3 N0 M0. Same thing you have here. T1 N2 M0, एक बढ़ा दो N3 हो गया M0, इधर का एक बढ़ा दो N2 हो गया, इधर का T3 में N1 जोड़ दो हो गया, T4A N0 M0. ठीक है? In the same way. So it is like one step, एक एक करके बढ़ाना है. Is that clear? Is that clear? Quick feedback. Can you move on? So far so good. ठीक है? So this is again very important for you to remember it. I know it looks a little bit overwhelming in the initial part, but as you practice once, you will be able to get a grip of it. There's no context at all. Clear है? ठीक है? चलो. So let's talk about stage-wise management. We'll talk about the stage-wise management of the gastric cancer. ठीक है? अच्छा, before we move down, if they ask you what is the most common route of spread for gastric cancer, the most common route of spread for gastric cancer, the answer is going to be hematogen. Now, all your stomach, your bowel is drained by your portal system that goes into the liver. So, if I say what is the most common site for secondaries, the most common site for secondaries, the answer is going to be, okay. The other route that you have, it is going to be lymphatics. Then it is going to be direct route of spread. That is your invasion. That is going to be your direct route of spread, right? They'll ask you how much lymph nodes to be removed. Remember, minimum lymph nodes or minimum number of lymph nodes to be removed for adequate staging. To be removed for adequate for an adequate Minimum number of lymph nodes to be removed for adequate staging. For gastric cancer, it is going to be for esophageal cancer. For esophageal cancer, it is 15. For colorectal cancers, it is going to be 12. And for the breast cancer, it is 10. So these are the various malignancies where these are the lymph nodes that you have to remove so that you can get an adequate staging. So minimum lymph nodes to be removed in order to stage gastric cancer 16, esophageal is 15, colorectal is 12, and the breast cancer it is going to be 10. It is going to be 10, right? Now, let's talk about the stage-wise management, right? Basically, we have two components where you have resectable gastric cancers and unresectable gastric cancers. Now, either ways, the surgery is the mainstay. So the surgery depends upon the location, right? If you take this as the representation of the esophagus, and this happens to be stomach. This happens to be your gastroesophageal. This happens to be your gastroesophageal. We divide the stomach into the proximal part, the mid body, and the distal. So this is what we call it as the proximal stomach. This is going to be the mid body. This is going to be right. We'll see where the tumor is present. If the tumor is present in the proximal part, is it present in mid body or is it present in the part, right? Now, if you look at the whole context of it, now, if it is present in the proximal stomach, the current guidelines that dictate for the proximal stomach is going to be total gastrectomy, is going to be total gastrectomy. For mid body tumors, we do subtotal gastrectomy. We do a subtotal gastrectomy. And for the distal portion, we do distal gastrectomy. We do a distal. So these are the preferred surgeries. These are the preferred surgeries in order to remove the part of the stomach when the tumor is going to be infiltrating. Now, when I say total gastrectomy, the entire stomach is going to be removed, right? In a total gastrectomy, we are going to remove the entire stomach. So, how do you reconstruct it back? So, after doing a total gastrectomy, I will anastomose the esophagus with that of the jejunum. So, you are going to perform here Ru and Y. So, go, Jeju, perform a Roux-en-Y esophagogynostomy. I'll quickly tell you what is a Roux-en-Y esophagogynostomy also, but in a short while we'll see. Now, it's a in a subtotal gastrectomy, how much stomach has to be removed to call it as subtotal? Around 60 to 70% of the stomach, around 60 to 70% of the stomach will be removed for a subtotal gastrectomy. Okay. Now, once you have removed the stomach for reconstruction, here you will go ahead with Roux and Y, the Roux and Y, gastro, jeju, there will be Roux and Y, gastro, jeju, When it comes down to the distal gastrectomy, in the distal gastrectomy, 30% of the stomach is removed. Yes, 30% of the stomach is removed. And after the stomach is removed, the reconstruction is done with the same context, that is your Roux-en-Y gastro, jeju, your Roux-en-Y gastrojejunostomy. In all these conditions, the lymph node dissections that you're going to do, so let it be any part of the stomach you're removing, you have to do a D2 lymph node, D2 level of lymph node dissection should be performed. This D2 level of lymph node dissection has to be performed, right? Followed by post-operative chemotherapy, followed by the post-operative chemotherapy, followed by the post-operative chemotherapy. Basically, we give platinum-based chemotherapy. You can remember the regime as ECF, that is epirubicin, cisplatin, and 5-fluoro and the 5-fluorouracil, right? If I say what is the current indication for a post-operative chemotherapy. To look at the current indication, the current indication for the post-operative chemotherapy, if the lymph nodes are positive, if there is going to be muscle invasion, the muscular invasion is present, if it is a T3 or a T4 disease, and if it is having a bulky lymph. In fact, the last two that I have told you is also an indication for neoadjuvant chemotherapy. They are the indication for neoadjuvant chemotherapy. They are the indication for your neoadjuvant chemotherapy, that is chemotherapy prior to the surgery, right? After you have done, you'll do post-operative radiotherapy as well. Once this is done, you'll do post-operative. So, you'll also perform a post-operative. There's a post-operative radiotherapy, right? Now, the radiotherapy is given to the stomach bed. It is given to the stomach bed. The basic objective is to prevent locoregional rectal. To prevent a locoregional. So this is all in all how you manage your patients of gastric carcinoma, right? So two surgeries that I would like to talk about. One is a Roux-en-Y esophagojejunostomy. Another one is Roux-en-Y gastrojejunostomy. We'll talk about both. So I'm going to talk about the Roux-en-Y. So the Roux-en-Y. So now in a Roux-en-Y esophagojejunostomy, let's try to understand. Saying that this is the esophagus, happens to be stomach. This is the duodenum, and continues across here. This goes into appendix, and this happens to be ascending colon. Now, when will you do a Roux by esophagogynostomy? When the entire stomach is going to be sacrificed. So this is the part of the stomach that we have removing it. So we've decided to remove the entire context of this. The entire stomach is now being removed. Once you remove the entire stomach, what are you left out with? Now you're left out with this esophagus that is present. Right? The duodenum that is left as a stump. Now, when you look at this happens to be the duodenum, this happens to be the jejunum, this happens to be the ileum. So what I'll do is I will divide the jejunum. So this duodenal stump is now closed, right? Stomach is removed. This is the jejunum that is present, the ileum that you have, the terminal ileum. This is how it is present, correct? So let's say until this point it was the duodenum, right? Until this point it is jejunum and then is ileum. I am going to divide the jejunum here. Normally we'll say 50 to 60 centimeters from the duodenojejunal junction. So once you divide the jejunum here, you've got two parts of the jejunum. I can call this as the proximal jejunum and this is what we call it as the distal jejunum. The two parts that you divide, the proximal jejunum, distal jejunum. I will take the distal end of the jejunum and make an anastomosis, right? So this is the esophagus that you have. So eventually when you come down, this is the esophagus. Now the distal end of the jejunum is being brought here. The distal end of the jejunum. Now this the distal end of the jejunum that is mobilized, and this is going to be continuous with the ileum. This is the ileum that you have. This is the appendix. This is the ascending colon. It is keeping. So this is the part where we made an anastomosis of the esophagus with the distal part of the CD stands for distal part of the jejunum, right? So that the food is maintained. Now you have the proximal end. So this is the duodenum which was left. The proximal end of the jejunum which is left is now going to be anastomosed. This is the proximal end of the jejunum now going to be anastomosed with the distal end of the jejunum, and here we are closing the duodenal stump. After closing the duodenal stump, this is where you're making an anastomosis. Right? So this is the duodenum. This is the proximal jejunum, and you're creating a jejunum. The reason why I want to still keep it, as most of you know, that the bile duct is going to open onto the terminal part of the second part of the duodenum. The bile that is going to flow from here will flow through this channel, and the patient which is going to consume the food will now go from the proximal end together be able to, right? This is what we call it as the Roux-en-Y esophago. This is what we call it as the Roux-en-Y esophago. Yeah. The same thing, if you do this with stomach, it will be called as Roux-en-Y gastro, right? So if I have to just conclude, same thing, that is your Roux-en-Y gastro to be the Roux-en-Y. It is the Roux-en-Y gastro. In a Roux-en-Y gastrojejunostomy, this is the esophagus. Let's say the part of the stomach that you have sacrificed it, right? This is the duodenal stump which is going to be left behind. So left the duodenal stump behind. I've taken the jejunum. I have made the anastomosis with the jejunum here. Jejunum continues to go into ileum, goes into cecum and then into the colon. The duodenum goes with the proximal end of the jejunum. Proximal end of the jejunum opens here. This is the stump that closes. You see the stump is closed in the duodenum. There is this gastrojejunostomy. This is the distal end of the jejunum, the proximal end of the jejunum. And then we perform the jejunostomy. Same thing, bile duct is to be opening onto the terminal part of the second part of the duodenum, which is here. You'll see the bile will flow through this particular channel, and the food that comes in through this channel continues, right? So this is for Roux-en-Y Roux-en-Y gastro. When you look at the anastomosis per se, one you will see there is gastrojejunostomy. Another one that you will see, another one that you have is your no. Another one that you have is a jejunum. Yeah. So this is all in all with respect to gastric carcinoma, right? All right, guys. So far, so good. So far, so good. So that's it for today. Thank you so much for joining. This concludes our discussion on the stomach. Tomorrow, we'll try to start a new topic. Uh, I think there are a couple of small topics which are left. For example, in stomach, we talk about gastric volvulus. We can talk about it. Gastric lymphomas. We can talk about it. Uh, Apart from that, uh, gist we have already covered it off. So I don't think there's anything left behind in gist. We can talk about trichomotor and phytomotor. So tomorrow we'll talk about gastric lymphomas. We'll talk about the gastric volvulus and tricho and the phytomosaurs. Okay? Thank you so much for joining. See you guys again tomorrow at 9 o'clock. Bye.